We are going live in 5, 4, 3, 2, 1. We are live now.
Good evening, all. I, Swati Kadia, on behalf of Eris Lifesciences, welcome you all to the Smart CME on the smart way to manage pain. Firstly, I would like to thank our respected experts for taking their precious time out and making to this event. And I also would like to thank the audience for attending this Smart CME. Before we begin our today's session, please allow me to give you a brief about Eris and this unique Smart CME. Dear doctors, Eris is a young and dynamic company launched in the year 2007. Eris is youngest among India's top 25 pharma companies. Operating with the motto of power of empathy and the truth of science, Eris has made a strong presence in multiple therapies, one of them being pain management. You will all agree with me when I say that in the last 20 years, smart solutions have evolved in all aspects of our lives, especially in the field of medicine. In fact, smart is the new way of life. But there is one critical aspect in medicine which is yet to evolve in a smart way, and that is pain management. Current therapies continue to ignore the complexities associated with pain management. While they may target the affected organs, they often damage the vital ones. Hence, after a long wait of 20 years, Eris introduces a novel COX-2 inhibitor, Hisaka, which contains palmacoxib, the world's only smart pain reliever. In osteoarthritis and joint pain, Hisaka offers targeted pain relief by preferentially blocking COX-2 in inflamed joints and smartly sparing COX-2 in the vital ones. With this, I would like to invite Dr. Abhijit Malvi, medical advisor with Eris, to discuss and deliberate on the smart way to manage pain. Dr. Abhijit, over to you.
Good evening, everyone. Myself, Dr. Abhijit. I'm medical advisor at Eris Lifesciences. Now, Eris is always at the forefront in providing learning educational platforms to the clinician, and this Hisaka Smart webinar is a part of our novel educational initiative. Now, we all know pain management is always a big challenge, and it is complicated by the hidden pain, which is hidden behind the perceived pain. And what is that hidden pain, and what is the novel smart way to prevent that hidden pain will be discussed in detail in this webinar. Now we have very renowned and experienced clinicians with us for this webinar. I would like to introduce Dr. Sandeep Suri sir. Dr. Sandeep Suri sir has 23 years of experience, currently serving as a senior diabetologist in Advanced Diabetic and Critical Care Hospital, Holy Care Hospital at Hisar. Dr. Sandeep Suri sir has served as a regional faculty in different societies like CCBDM, CCGDM, CCDRM, TDM, and RSSDI. Dr. Sandeep Suri sir has received several awards such as Diabetic Awareness Award at Diabetic India 2018, Excellence in Diabetic Care 2019 at RSSDI 2019, Gold Medalist in Fellowship in Diabetic Management at CMC Vellore. Dr. Sandeep Suri sir has delivered several lectures in Apicon, Speedcon, and National Insulin Summit. He has conducted several clinical trials as an investigator and co-investigator. He has several publications in his name, and he is on editorial board of many reputed journals. He is actively involved in social work for diabetic foot management also. And we have the renowned orthopedician with us, Dr. Abheek Kar sir. Dr. Abheek Kar sir is a senior consultant at Shoulder and Elbow Unit, Apollo Multispeciality Hospital, Kolkata. He has completed MBBS from Kolkata National Medical College and MS Orthopaedics from Savai Mansingh Medical College at Jaipur and MRCS from Edinburgh, UK. Dr. Abheek Kar sir has completed higher surgical training from ERCAD, France, American Academy of Orthopedic Surgeon, Chicago, San Diego Shoulder Institute, Singapore General Hospital, and University Hospital, Madrid, Spain. Dr. Abheek Kar sir has served as a national and international faculty for orthopedic courses. Dr. Abheek Kar sir has published several articles in national journals and has contributed chapters in orthopedic textbooks. Dr. Abheek Kar sir is associated with Atletico Kolkata Football Club and Sports Authority of India. So with this, I will like to hand over the session to our first speaker, Dr. Suri sir. Over to you, sir.
So very good evening, friends. At the outset, I must thank Eris for bringing out an excellent platform for discussing something which is very, very new. Just we are all enjoying, or we are very proud of Chandrayaan 3 launching from ISRO. I think Eris needs all congratulations for bringing out an excellent molecule, which we were looking for management of pain management for pain management. Yeah. So can I see my slides? Let me see. Yeah. Yes. Slide visible? Just hello. Abhijit, slides are visible?
Yes, sir. Yes, sir. Slides
Okay.
are.
So regarding pain management, if we go back, since ancient times, we are using herbs, plants-based products for management of fever, pain, inflammation. We always require something to manage pain. And friends, aspirin was discovered in 1879, so way back. So 2 centuries back, we had aspirin. After that, we have various painkillers molecules like COX-1, COX-2, selective, non-selective. Many came into the picture and many were distributed also. And till now, you can say the most commonly prescribed molecule that is there always in our prescription is a painkiller. Most widely prescribed drug for pain, fever, inflammation are non-steroidal anti-inflammatory drugs. World over, if you go by the prescriptions, 73 million prescriptions are there written yearly, and approximately 30 million people are taking NSAIDs daily. Most common prescribed or most commonly used OTC product. And if you go by the data of global and Indian studies, showed that the total number of NSAID prescription ranges from 15% to 40%. So I think we don't have any prescription without the painkiller. And many times our patients are not telling you, they are coming out with the prescriptions or the coming out that they are taking some medication. But if you ask them, something will come out from their pocket or something will come out from their bag. Either they are having diclofenac, or they are having ibuprofen, or they are having nimesulide or paracetamol. So most of the time you will find out that they are having this. Why they are consuming? Migraine is there, osteoarthritis there, knee pain, shoulder pain, backache, neck pain. So they are having these medicines always as in their bag, always. And the reasons for self-medication with NSAID in our country are basically they are saving money in terms of consultation fees. They don't want to come to us, and because they think that it will take a lot of time. I can get this tablet right from the corner, the guy sitting at the corner shop of the medicine shop, and saving time and avoiding travel. So they take it and they think it is simple to take a painkiller. That's all. And there are certain studies which have shown that disclosed prevalence of analgesic self-medication ranges from 23% to 90%. So there are 2 things. One thing is written prescription of NSAIDs, and another hidden prescription or hidden intake of NSAIDs. So if a molecule or a class of molecule is being used so much routinely in our day-to-day schedule, I think that requires something we have to look at, that whether we are having them in a safer zone or not. We are giving the benefit to the patients, or we are leading to certain harms. So if you go by the literature, we are always worried, be the physicians or orthopedicians or any specialty, we are always worried related to the side effect profile of the NSAIDs. So I am going to talk about certain things which make NSAIDs to be looked in a different way. That is, I will be talking about the side effect profile of the NSAIDs. So are the simple OTC products? They are noise. They are just they are not causing any harm. No, friends. NSAIDs are leading to certain specific harms, specific toxicities. There can be 3 types of scenarios. There can be acute toxicity. That means you took a single medication or a overdose medication, and that led to damage to the various organs. There can be chronic toxicities also. That means long-term duration and higher the dose of NSAIDs taken, that leads to organ dysfunction. But sometimes the patient is so vulnerable, like your patient of CKD having low EGFR, or your patient of liver disease having a moderate to severe liver dysfunction, or a patient with bleeding dysfunction, bleeding disorder, thrombocytopenia, or elderly population, where sometimes even a single dose can lead to a lot of treatment-related side effects. So if you go by the pharmacological effect of NSAIDs, NSAIDs basically inhibit cyclooxygenase isoenzymes. These are the enzymes which are required, which are basically required for inflammation, which are also required for maintenance of the tissues, maintenance of the organ function. So we can have physiological stimulus where COX-1 are basically housekeeping molecules. They are housekeeping, they have got housekeeping function, and mainly they are protective. They are protective for us, and mainly the protection is at the level of stomach. Also, they are protective for endothelium. They are required for platelet proper functioning, and also proper functioning at the renal levels. We have got thromboxane A2, we have got prostaglandin I2 and prostaglandin E2 under the umbrella of COX-1 constitutive molecules. So these are they have got various functions, but overall COX-1 is having that is required, that is a housekeeping function that is there for a physiological functioning. Whereas COX-2 is inducible enzyme. It has got inflammatory stimulus, and it is activated once the tissue is injured, and also once there is inflammation, the level also increase multifold. That leads to increased synthesis of pro-inflammatory prostaglandins. And they are basically functioning at the level of macrophages, leukocytes, fibroblasts, and endothelial cells. So they are basically tuned for inflammation. So we have got two types of coxinase enzymes. These are COX-1 and COX-2. We also call them prostaglandin endoperoxidase synthetase, PGHS1 or PGHS2. PGHS1 is COX-1, PGHS2 is COX-2. So after this, if you go by the function of COX enzymes, arachidonic acid is a raw material, and that is being taken care by COX-1 and COX-2, and there is various organs and tissues which have got different mediators released by this enzymatic activity on arachidonic acid. COX-1 in platelets leads to formation of thromboxane A2. And the function of thromboxane A2 is vasoconstriction, platelet aggregation, platelet activation, ultimately leading to thrombosis. So we don't want this, but somewhere we may be requiring it when you are having bleeding. When you have a bleeding disorder, we may be requiring TXA2 also. Gastric mucosa, COX-1 activity leads to prostaglandin E2 and I2 formation. They are basically gastric protective molecules. At the level of joint, where when there is inflammation, then prostaglandin, the COX-2 is activated and upregulated. That leads to prostaglandin E2 and I2 formation, and they mediate pain and inflammation. At the level of endothelial cells, we have got COX-2, and they are protective prostaglandin I2, which leads to vasodilatation, endothelial function maintained, improvement in nitric oxide synthesis, and also availability of nitric oxide at endothelial cells, and decreasing platelet aggregation. So we have got varied spectrum of functions from the raw material, that is arachidonic acid. So we can have various different implications at different organs and different tissues when we are using COX-1, COX-2, or NSAIDs type of molecules. So classification wise, this is KG Tripathi classification, our textbook of pharmacology. The NSAIDs can be divided into non-selective NSAIDs, which have got both COX-1 and COX-2 activity, inhibitory activity, preferential COX-2 inhibitor molecules, which are having preferential action on COX-2, but have got somewhat action on COX-1 also. So for non-selective COX inhibitor, we have got aspirin, indomethacin, ibuprofen, naproxen. These are the usual molecule. Also, we are using mefenamic acid, ketoprofen. They are non-selective, and they are COX-1, COX-2 both. Preferential COX-2 are nimesulide, diclofenac, isoclofenac, meloxicam, and etodolac. And most commonly, we are using these type of molecules. There are selective COX-2 inhibitors, celecoxib, toricoxib, and paroxib. So these are the selective molecules. Roxfrecoxib and valdecoxib, they are out of market, but we have got selective COX-2 inhibitor. They only act at COX-2 level and they inhibit this enzyme. They leave COX-1 apart. Then we have got analgesic antipyretic with poor anti-inflammatory action. And meantime, we are using these molecules in higher dose to take care of some amount of inflammation to give some analgesic effect. This is paracetamol. So why we require these type of molecules? Because the issue was the safety of the molecule, class of NSAIDs. On one part, that is COX-1 part, which has got physiological action, and that is protective for your GI tract. On another arm, you have got COX-2, which is protective for your endothelium and platelet activity and your cardiovascular and renal tissues. So we require a proper balance. If we inhibit COX-1 and leave COX-2 as such, we are having more problem with our GI tract. If we inhibit COX-2 and leave COX-1 as such, we may be having safer molecule for GI tract, but we will be having many issues with cardiovascular and renal endpoints. So we wanted something balanced. So this is the side effect profile or the target areas where NSAIDs work, or we can have the side effect profile of the NSAIDs. The foremost issue is GI related toxicities. So here you can have various type of common side effects like dyspepsia, heartburn, peptic ulcers, they can be there. And very rarely you can have perforation, very rarely. NSAIDs associated point prevalence of GI related complications is around 30%. But the literature is underreported. I think we will be having more if we go to real world evidence. I think 70% of the patients, they have got GI related side effect to NSAIDs. Now, let's go to the mechanism of this GI related side effects of NSAIDs. NSAIDs basically, if you see the mucosal surface that is of the GI of the stomach, that is mucosal surface is hydrophobic. And it is preventing your gastric acid exposure. But due to disintegration of phospholipid layer under the effect of decreased prostaglandin secretion by the effect of NSAIDs, this layer gets disrupted. And this layer gets exposed to the gastric acid, and also there is direct toxicity of NSAIDs, leading to erosion and formation of ulcer. Underlying the pathology is mitochondriopathy. There is bioenergetic failure at the level of mucosal cell by uncoupling of oxidative phosphorylation. Also, there is upregulation of inflammatory cytokines like TNF-alpha and also adhesion molecules and nuclear factor kappa beta at the gastric mucosa. And there is another interesting story of ion trapping theory. And what this tells you that NSAIDs are basically non-ionizable and lipid-soluble molecules. Once they diffuse through the mucosal barrier under the acidic pH, they get into the cytosol of gastric mucosal cells where the pH is neutral. And now they get ionized. And then they also become lipophobic. And that leads to toxicity to the cells. So ultimately, you can say that gastric acid and NSAIDs both work synergistically to produce necrotic factor to produce damage to the mucosal barrier. Also, not only it is at the level of stomach, lower GI tract also shows lot of side effects, lot of issues like petechiae can be there. There can be erosions, there can be variceal formations, there can be there, reddish folds can be there, loss of villi and ulcers can be there. And that can be there in 71% of NSAID users. There can be direct mucosal breach in 51% of chronic NSAID users. They are all reported in the literature. And another important thing that is coming up, there is also gram-negative enterobacteria that helps in inflammatory cascade, allowing the toll-like receptor 4 to be upregulated, and that leads to pro-inflammatory cytokines release. That's why the theory of probiotic helping into prevention of NSAID-related GI side effects that has come up. If you compare the molecules regarding the GI-related side effect, COX-2 inhibitor are somewhat safer, not much, but somewhat safer in comparison to non-selective NSAIDs. Diclofenac lead to 1.8 hazard ratio relative risk, whereas ibuprofen 3-fold higher, naproxen 4-fold higher. So these are the molecules that can lead to more GI-related side effect, but you are somewhat protected when you're using COX-2 inhibitor because COX-1 activity remains intact and you have got no inhibition of prostaglandin at mucosal level of GI tract. Coming to another adverse event, other target organ which gets targeted by the NSAID-related issues, it is cardiovascular toxicity. Now, in cardiovascular effect, the CV complications can be myocardial infarction, can be heart failure. They have been highlighted as another major stumbling block against use of NSAIDs. We were very happy when we got COX-2 inhibitor. That means we have now safer molecule. These were the magical bullets which came to us, and we were using it in lot number of patients. But that issue was only, you can say it was very smaller, it was very short time when we were enjoying COX-2. Trials came into picture like REACH trial, Vigor trial, that came into picture that led us that rofecoxib, valdecoxib leads to 4-fold, 5-fold increase in myocardial infarction, 2 to 3-fold increase in heart failure, 2 to 3-fold increase in arrhythmogenicity. And all these things led to the withdrawal of these molecules from the market. Now, the issue was that there was imbalance between prostaglandin and thromboxane. So that was the key issue here. And even they say that even 7 days of NSAID intake was associated with increased risk of myocardial infarction, with the risk plateauing after 30 days of use. That means if you take NSAIDs for 7 days, you are always at high risk of developing acute myocardial infarction up to 30 days of indexed dose. So why it is happening? There is eicosanoid imbalance. Basically, there is eicosanoid imbalance. By uses of NSAIDs, there is prostaglandin, prostacyclin, which are coming down, and there is increased activity of thromboxane ratio. This prostacyclin and thromboxane ratio increases, and there is increased cardiovascular events. Also, even the intermittent user in the real world use of NSAIDs, that was associated with significantly elevated risk of cardiovascular events. And there can be various molecules which have come up, specifically COX-2 inhibitor, like rofecoxib, valdecoxib. I will talk about celecoxib in a few seconds, but those are the molecules which has been highlighted. They increase thrombosis, they increase stroke ratio, stroke issues, myocardial infarction, and heart failure, all 2 to 4-fold, 2 to 5-fold higher than the placebo. But something which is very interesting to see this, the theory behind the cardiovascular events related to NSAIDs, it is the comparative studies. They have shown that CV events are compound specific. They are, rather than being a class effect of all COXIBs, it was more of compound specific. And there is a trial, that is precision trial, that came out and that compared the celecoxib with naproxen. And they compared these two molecules, and they look at that these two molecules are having similar risk of CV events. There is no increased risk of CV events with celecoxib. That's why we have got some market with celecoxib, but always worried that this molecule, this class of molecule, can lead to eicosanoid imbalance, increasing thromboxane A2 and decreasing prostacyclins, prostaglandin I2 going down and thromboxane coming up. So there can be increased activation of platelet. There is increased aggregation of platelet, more vasoconstriction tone, decreased nitric oxide, endothelial dysfunction is increased and leading to clumping of platelet, constriction of vessels, and cardiovascular events. There can be other issues also. Direct toxicity of COX-2 inhibitor on cardiac myocytes by decreasing prostaglandin I2 and E2 at the myocardial level. Also, when you have got issues related to renal NSAIDs, side effect of renal, then anything related to renal injury, there can be increased sodium absorption, there can be increased water absorption, there will be hypertension, ultimately leading to increased long-term CV risk. So we develop increased CV risk, increased risk of heart failure, and increased long-term CV risk also. And both even short-term use of NSAIDs or even intermittent use of NSAIDs can put patient on high risk for CV-related issues. So looking at this data, rofecoxib withdrawn, valdecoxib withdrawn, lumericoxib withdrawn, and toricoxib is not approved by US FDA, but has got equivalent risk in comparison to rofecoxib and valdecoxib. Celecoxib have somewhat, you can say it's still surviving because of that trial, that is a precision trial that compared it with naproxen and found out to be non-inferior in CV-related issues. Now coming to another target organ that can be impaired, that can be involved, that is renal toxicity. So there can be, because you know that kidneys are the major excretory organs and they require around 25% of your cardiac output. So there can be two types of damage at the renal level. Functional damage, that means acute dosing, acute overdosing, or even single dose when you have got impaired renal function, you can have functional damage. By looking at this picture, you can just formulate that there is afferent arterial dilatation under the effect of prostaglandin E2 and I2 that leads to increased blood supply to the glomerular basement membrane. There is a vasoconstrictor tone at efferent arterioles by angiotensin II. So if you inhibit these prostaglandin on afferent arterial part, there will be decreased blood supply to the Bowman capsule, decreased blood supply to the glomerulus, leading to decreased intraglomerular pressure and reduced GFR. This is direct functional damage that by using short course of NSAIDs, the GFR decreases. Then second part is inflammatory damage that leads to more vascular and inflammatory damage, more vasoconstriction, ischemic damage, and inflammatory damage to the glomerulus and also to the tubules, leading to the spectrum of damage to the kidneys. And this happens, you can say it's more than in Indian studies, around 30% patients, they have reported renal related side effects. And that is even the acute kidney damage can be there in the first 30 days of NSAIDs therapy. So if you see the type of molecule or for the renal issues, you can see that all of them, even COX-2 and COX-1, they have got chances of damaging kidneys if their duration of usage is higher or higher doses is being used. But more of them is having COX-2 inhibitor, which has got more damaging effect on your renal myocardium and ultimately leading to hypertension in 25 to 30% cases, and also leading to increased risk of heart failure by 2 to 4-fold in comparison to placebo. Another target organ is your lungs or your respiratory system. Very commonly, we are all aware that there is aspirin enhanced or aspirin associated enhanced respiratory disorder. That is, allergic reaction to aspirin is commonly known to us. And these patients are having polyps in the nostrils, they have got allergic asthmatic conditions, or they have got increased eosinophil count in their blood, or IgEs are on higher side, and they have got characteristic aspirin related allergy, and single dose of aspirin can lead to very severe bronchospasm and they will end up in emergency. So that is also well known to us. But issue is that there is an imbalance. When you use NSAIDs and non-selective NSAIDs specifically, there is COX-1 inhibition and there is upregulation of leukotriene pathway, and there is increase by leukotriene pathway, there is increased interleukins 4 and interferon alpha gamma, they are increased. They are all pro-inflammatory, leading to bronchospasm and allergic reaction. Also, leukotrienes are basically stimulator for your mast cells and eosinophil cells. And prostaglandin E2 is inhibitor for your mast cell and eosinophil cells. So that inhibition of prostaglandin E2 leads to upregulation of mast cells and eosinophils, and that leads to increased allergic reaction into your upper airways and also in your lower airway tract. And also remember, we were not using NSAIDs during COVID because of increased propensity of developing community-acquired pneumonia with NSAIDs. So NSAIDs are basically not good for your respiratory tract, and we were not using COVID. And I think we all remember that it was only paracetamol that was recommended in COVID era. Another organs are there can be neurological issues like aseptic meningitis, psychosis, cognitive dysfunction that can be there. And these are commonly reported neurological side effects. And also, very importantly, there can be intracranial hemorrhage due to thrombocytopenia or due to functional dysfunction at the level of abnormality at the level of platelets. Then hepatotoxicity from NSAIDs can occur at any time after drug administration, but likely most adverse reactions usually occurring 6 to 12 weeks after initiation of therapy. You can have acute hepatitis like picture, or even fibrosis, or even cirrhotic changes has been reported with use of NSAIDs. Then NSAIDs can interfere with the release of mature ovum, also, and leading to ovulation failure, also leading to infertility. There is decreased sperm count and decreased sperm motility also when the patients are on NSAIDs. Damage to the testes and damage to the seminiferous tubules that has been reported with the use of chronic NSAIDs. And spermatogenesis is decreased when the patients are on NSAIDs. So if you are dealing with the cases of infertility, remember you have to take the history of NSAIDs intake also. So if you see the adverse events, they are all organs, they are having these type of issues when we are using NSAIDs. But NSAIDs are essential for us. We cannot go away without NSAIDs because pain is a
Sir, your voice, we have lost your voice, sir. Dr. Sandeep Suri, sir.
Rishi, are you there?
I think there is some connection issue. Yeah, sir, there was some internet issue, sir.
yes. I think I finished my talk, or
Sir, last slide was there. Last slide.
Okay. So that was I was summarizing, and the issue was that even the small, if even the shortest intake of the NSAIDs can lead to problems, but we cannot go away with the uses of NSAIDs. We want NSAID, and that should be very, very safe NSAIDs. And I think we are going to have a lecture on a safe molecule, and that Eris has brought into the market, and we will be having more learning from that. Thank you for the patience listening.
Thank you, sir. Thank you for such a detailed presentation on NSAID related toxicity. It is really surprising to know such a commonly used drugs are implicated in so many adverse effects. So thank you so much, sir. Now we have our next speaker, Dr. Abheek Kar, sir. Over to you, sir, for pulmonology lectures. Dr. Kar, sir.
Yeah, good evening, everybody. Can you hear me?
Yes, sir, we can
Yes.
hear you clearly.
Yeah, I'll just start my slide. Dr. Suri, congratulations on the wonderful explanation. And it was quite it was going back to my pharmacological days,
Yes.
a kind of a revision. Left pharmacology 30 years ago. So I'm going to do my screen sharing. So just yesterday yesterday I was talking to some doctors and we were discussing how the pharmacological industry has stopped investing in new molecules. I guess everybody would agree on that. And now most of the market is driven by nutraceuticals. Everywhere you go, some nutraceutical medicine is coming, but very few molecules, name antibiotics, some painkillers, some disease-modifying drugs, very few molecules are coming in the market. And this was a welcome change. And I immediately jumped the gun more. The reason was that I was more interested in this molecule rather than the concept of coming and talking on the webinar. So I did my little bit of research on that, and it's an entirely new molecule. It's very exciting. So far, so we have in India, apart from itracoxib, we are not exposed to any much molecules of COX-2 inhibitors. Celecoxib is not widely used, at least by orthopedic surgeons, and we are always worried about safety for elderly population. My mother was given itracoxib, and I was always worried about her leg swelling. She did have leg swelling. She did have fluid retention, and I was very skeptical. I gave her a short course and I then immediately withdrawn. So side effects are there. We as orthopedic surgeons don't encounter such side effects because probably we don't have the latitude to identify there or look for the side effects. It's like we just give them painkillers and then we forget about it. And then they probably land up with some other doctor, physicians later on. Now, see, this molecule is entirely new and it's a very elaborate slide which was there, and half of the slides were covered by Dr. Suri, so I'll skip those slides. So we'll just talk about the salient points regarding this molecule, how it is better than other molecules we have seen so far. And as revision, we all know that this molecule is a COX-2 inhibitor. We are specifically involved in only inflammation, anti-inflammatory action. We don't want the actions on the gastric side or the platelet side or the endothelial side. That's why the selectiveness of this particular molecule is very important. So I'll just skip a couple of these slides because it's the same slide which we had. Now, this is again a kind of a revision where we know how the COX-2 inhibitors work there. Problem is that we have to balance in between the cardiovascular side effects and the COX-1 effects there. So that is where the molecule is important. Now, as you know, this selectiveness of these COX-2 inhibitors is not is specific for a brand. Like rofecoxib, valdecoxib, itracoxib, although they are the same group of medicine, they each have the different side effect profile. And that's why it's very important for us to select the right proper medication. So we all know I used rofecoxib in my internship days and valdecoxib, then suddenly it was withdrawn from the market, citing cardiovascular effects. And I think, I don't remember the company, they had a $1 billion or $1 million lawsuit for this. Of course, this is all history. Very important to learn from history that why these were banned, although coming out of clinical trials, nobody even thought of that this will end up with serious cardiovascular side effects there. So that's what the drug industry is all about. When we do trials, sometimes post marketing studies are different from the trial studies there. And this is what we are confused all about. How do we select whether we select a COX-2 inhibitor, which is better in gastrointestinal side effect profile, but has the increased cardiovascular effect. If you're trying to avoid cardiovascular side effects, you have a GI side effect. So I think somewhere in between lies the answer there. So, and this is where the therapy gap remained with these COX-2 inhibitors. And although I have been so far kind of satisfied with the previous COX-2 inhibitor regarding the side effect profile, but we do see some side effects once in a while, and that makes us wonder that whether this new group of medicines will be of some of use in reducing the side effects or not. So this is the molecule polmacoxib, and very interesting that although it has been approved in most of the studies I was going through are in Korea, and the studies are very encouraging, and recently has been approved in India, and we'll soon get to use it firsthand. And the interesting part it is, although it is COX-2 inhibitor, it also inhibits the carbonic anhydrase 1 and 2 receptors. Now, why it is important is that I'll show you in the next couple of slides that this has a specific action in the joints. The other COX-2 inhibitors have a overall anti-inflammatory action, but this has been selectively used in osteoarthritis patients. We're going to just skip these particular slides. Okay, this is important. So this is the carbonic anhydrase activity. Now, in patients with osteoarthritis, where there's some inflammation going on, the carbonic anhydrase, which is there in the joints, gets inhibited there by the particular medicine. But the carbonic anhydrase in the other tissues, which are there, but there is no inflammation, this particular molecule will not affect the carbonic anhydrase activity in such tissues like the heart, the GI, the platelets, and the kidneys. So the effectiveness in the side effects of that particular organ will be less. And it is because of this aryl sulfamide moiety, which is very similar to celecoxib, valdecoxib, and that's why these particular previous molecules had very selective COX-2 inhibitory actions. And like I said, it has a dual action COX-2 inhibitor as well as a carbonic anhydrase inhibitor. Now, in this particular slide, as you see, in tissues where there is carbonic anhydrase deficient tissues like the inflamed joints, in such areas, the activity of polmacoxib is better compared to normal tissues where you have carbonic anhydrase activity is there. It is the number of such molecules are high, but the activity level is low. Can you see here? The carbonic anhydrase. So you have this molecule, let's say you have an X gram of molecule. Now, when it goes into tissue like the blood vessels or cardiovascular tissue, it can bind to carbonic anhydrase COX-2 either ways. But in inflamed joints where the carbonic anhydrase activity is very less, it preferentially will go and bind to COX-2. So you have that X gram of drug which is fully available for COX-2 activity. That is where it is important. Again, it's the same repetition of what I said. It is more effective than celecoxib and valdecoxib, and the dose is very low actually. And if you noticed, I'll give you the dosage later on. The low dose administration of polmacoxib is believed to have a negligible effect on overall carbonic anhydrase function, especially in the circulatory system. It somehow doesn't affect the circulatory system compared to the other COX-2 inhibitors there. So the uniqueness of polmacoxib lies in the fact that concentrations are low, but it can accumulate in the whole blood there. If you see this particular slide in green, the line there, the residence time of pulmocoxib is longer in the inflamed osteoarthritic joint compared with the blood. So patients who have osteoarthritis with some inflammatory activity going on, especially with acute inflammation, the drug stays there for a longer time compared to the whole blood in the blood. So it will kind of migrate into the joint compared to the blood. So that's where it's important that it is very selective in osteoarthritic joint. And since the drug kind of migrates into the inflammatory joint, the less amount of drug is available for side effects there. So you have like X gram of drugs. Let's say the whole of drug out of that 90% goes into the joint, and only few percent is left for side effects there. So the incidence of side effects would be definitely lower. And the same thing which we discussed earlier. So it kind of is cardioprotective, or I would rather say not protective. It does not cause so much of cardiovascular side effects by not affecting the prostacyclin. So that means there is less chance of thrombosis. It prevents cardiomyocyte hypertrophy. So one of the side effects of COX-2 inhibitors was hypertrophic cardiomyopathy. So it prevents cardiomyocyte hypertrophy there. So these are the two ways it is beneficial in cardiac areas. And similarly in gastrointestinal and renal areas, it is safe. The reason is the carbonic anhydrase is abundant there, and that drug, since it is non-inflamed tissue, it will not go and attach there. The slide I showed you there, it's not inflamed, it is not going to attack the areas of GI tract, lungs, liver, gallbladder, urinary bladder, and kidney. Now, this has got a pharmacokinetics, which is kind of confusing for to begin with. Now, it has an absorption time, Tmax, somewhere between 5.5 to 72 hours. And it's got a varied time, absorption time. So that means it can take a quick absorption, it can take a delayed absorption. And the main areas of excretion are through feces and less through the urine. So it is kind of metabolized more in hepatic and less in the renal system there. This is a comparative chart. Now let's see heterocoxib. Second one, palmocoxib. Both are COX-2 inhibitor. Now palmocoxib is a tissue selective COX-2 inhibitor. Like I said, it works specifically in the synovial joints, synovial joint. That is very tissue selective. And the dosage is just 2 milligrams. You can imagine the less dose. Sorry. Now look at the half-life. Now, so although half-life is 5 days, it is given once a day. Now, I find this particularly specifically useful that, let's say somebody pops in a tablet, the effect may linger on for many days. So kind of beneficial for patients who can take it on a SOS basis. This is my observation. I don't know how practical it is going to be once I start using it. And the studies have been compared with celecoxib. Most of the studies are with celecoxib, where they found that it is superior to celecoxib. And the GI safety is similar to celecoxib there. The most important part is the cardiovascular side effects, which is high, moderate in most of the drugs, and so far none has been observed to date. So practically, it is absolutely safe from the cardiovascular point of view. The dose again, let me repeat, it is 2 milligrams once a day, not to be exceeded. It is not used in children less than 18 years because no data is available there. Contraindications like any other drug, patients who are hypersensitive, especially who have got fixed drugs reaction to COX-2 inhibitors, patients who are hepatic impairment. Now, it is not mentioned the what about hepatic impairment is the one where we can use it, or renal impairment. Do we use it in mild renal failure or not? But the safety profile of these drugs will only be known further when we start using it on a day-to-day basis there. Again, nursing mothers, pregnant mothers, contraindicated, and patients with active peptic ulcer or active GI bleeding. Very important. Patients who had a history of peptic ulcer or had a history of GI bleeding, they can be given. But if somebody has an active ulcer, then it's safe not to give those medicines. Similarly, in elderly patients, although they may not have any disease, they may have slightly higher creatinine levels or slightly higher elevated liver enzymes. Many of these are on some medications which can have a synergistic action on the organs there. So you have to be careful in this elderly population there. Apart from patients who are taking low dose aspirin for medical reasons, other NSAIDs should not be given. And that's why you should not be combining with, let's say, ibuprofen, or many of these patients also are on painkillers. It's very important to warn them that if you are on any other painkiller, please stop that. Similarly, patients who become dizzy or drowsy, they should be kind of warned, especially pilots, heavy machinery operators, and people who are driving long distances. And the last line is kind of a sad thing for many people. So kind of avoid drinking alcohol. The reasons are common sense, because it can risk the incidence of ulcers and GI bleeding there. So this is the drug interactions you have to be aware of. Ketoconazole, the antifungal agent, AC inhibitors. Many of these patients are taking antihypertensive, diuretics, lithium, methotrexate, anticoagulants, cyclosporin, and corticosteroids. The clinical trial, I'll straight away goes to the phase 3 trial. You see, the phase 3 trial was a 6-week study. It has been found that it is superior to placebo. It is non-inferior. It means equally effective as celecoxib. Equally effective. Then a long-term study of 6 months has shown that there are no serious drug-related adverse effects even at 6 months there. And although there were some adverse effects, they were mild to moderate. So this is the phase 3 trial, and they compared with celecoxib and placebo treatment. So now the question which people will ask is, why should I use it? Is it better? Yes. Statistically significant, it is better. As you can see, the placebo has a 46.5% pain relief of signs and symptoms of osteoarthritis. Celecoxib 54.5 and 71.9% in palmacoxib. It does have a quicker onset of relief compared to celecoxib and placebo. We are not comparing it with aspirin or diclofenac sodium or ibuprofen. We have only compared with the particular COX-2 inhibitors. So don't expect that this drug is going to act immediately. Because as we've seen, that absorption time is kind of varied between 5.5 to 72 hours. And again, reiterating the fact that there are no drug-related serious side effects, and whatever side effects were there in the mild to moderate category there. So this is what the kind of take-home message is, that compared to celecoxib, it gives you a quicker onset of pain relief and symptom relief in osteoarthritis. We are not talking about rheumatoid arthritis. We are not talking about other inflammatory disorders like tennis elbow, frozen shoulder. I'm sure we'll have extensions of study of these drugs and other medical conditions there. And the best part about this is the cardiac safety. So I would kind of summarize this thing in the fact that it is safe cardiovascular in cardiovascular profile, safety profile. The GI side effects are lesser compared to other COX-2 inhibitors. It is potent in the sense that it is efficacious, works better in pain relief compared to other COX-2 inhibitors. And I am looking forward to using this molecule and probably will contribute to post-market study for this particular brand of drug, and wish Eris Life Science all the best in this new launch. Thank you.
Thank you, sir. Thank you so much for these wonderful insights on pulmocoxib. Sir, there are 3 to 4 audience questions with us. First question is for Dr. Sandeep Suri, sir. Sir, the first question is, what are the precautions should be taken for using NSAIDs in patients?
See, if you want to use any type of NSAIDs, suppose you are using diclofenac or ibuprofen, few things are important. See, the liver and kidneys, these are the 2 important organs. The functions of these 2 has to be looked at. Enzymes has to be seen, EGFR or albuminuria has to be seen, or there is any GI related side effect history previous of ulcer, chronic alcohol intake, that has to be taken care also. Then any history of peptic ulcer or any endoscopies has been done, that also has to be taken. And alcohol, that is very important. If you combine NSAIDs with alcohol, then there can be 3-pronged action that can be damaged to your gastric glucose. And whenever you are using NSAIDs, the principle is that shorter duration and the smallest dose. So that is a thing. But still, we have got evidence even the single dose can lead to problems. Even 7 days the duration of therapy can lead to a lot of problems. So we wanted to have the safer molecule. So option is that these are the molecules. This is the newer molecule, the smart NSAIDs, which are smart NSAIDs that work at carbonic anhydrase when carbonic anhydrase is on higher side, COX-2 when COX-2 is on higher side. So that is very simple to understand, and leaving COX-1 apart as such. There is also, it remains more in the blood in comparison to plasma. That is the biggest benefit with this NSAID class, because if you see the other NSAIDs, they are having 75 to 80% protein binding, and they have got very high plasma level, and that is the key thing to get the more plasma level to reach to the all organs which are inflamed. So here the molecule is in the blood, remaining in the blood more in comparison to plasma because of binding to the carbonic anhydrase. So that adds to the safety and precision. The precision of the attack or precision of the functioning is, I think it is excellent with this newer molecule.
You mentioned the shortest duration. So what is that shortest duration for any NSAID or commonly used NSAIDs?
It is, yes, the prescriptions can go up to even 7 days or 15 days, but there is no recommendation that this is the shortest. They have just mentioned a line that it should be shortest duration of use of NSAIDs. But I think even when you stop writing the drug, even you stop that, now it is okay, but the patient feels that he has to take the painkiller continuously, and the prescription ending at 7 days or 10 days is never followed, and most of the time the patient keeps on taking NSAIDs, these painkillers. So that theory of having shorter duration, I think that is not applicable practically.
Sir, there is a question for Kar, sir. Sir, as you are told, etoricoxib has led to the pedal edema in your mother, sir. So, what position or what is the place of therapy of the pulmocoxib, considering the side effect of the etoricoxib-like drugs, sir?
I think too early to say, but as per whatever phase 3 trials have said, they have not mentioned any such side effects there. And etoricoxib or like any other NSAID has been known to cause water retention for sure. And that is the common reason why these patients, especially who are hypertensive elderly, they retain water. And it will be naive for us to say that pulmocoxib will not have these side effects. What we want to see is that what is the incidence and is it reversible or not. The etoricoxib, I remember, most of the patients after they stop the medicine, it is reversible. So that is a kind of a reassurance I give them. So let's see how it goes.
Sir, there is next question. Sir, for how long you can use pulmocoxib?
I think the phase 3 trials have given it for 6 weeks,
6 weeks.
then for 24 weeks, 18 weeks and 24 weeks. And there was a 6-month study which I was not aware, although it is there in the slide. The Korean study was for 18 weeks. For healthy, okay, these are healthy volunteers. Now remember that. Now, there's going to be a difference in a 70-year-old patient or a patient who is 50-year-old, 60-year-old with some comorbidities. I think Dr. Suri mentioned about shortest duration, this thing. Now, the practical experience I've had with all these drugs is, let's say you have an inflammatory response in the body, and in the pathology which we read, the inflammatory response can take 3 weeks to 6 weeks to subside, somewhere around that 3 weeks. Just an acute inflammation. So technically, we have to give an anti-inflammatory response drug for at least 3 weeks. So that's what I do. So if I have a patient who's got some inflammatory thing, I give it for 3 weeks or 20 days. And I have not encountered any such serious side effects. There was a study done for aceclofenac. They did a study for 3 years of giving a sustained release aceclofenac, and they compared with placebo, and they did not find any such increased incidence of renal, hepatic, cardiac, or such side effects. So, although yes, we are scared of these medicines, but like certain molecules are much better than other molecules.
Right, sir. So, sir, while using NSAID, is it effectiveness first or safety first for you, sir?
I think a balance between those. There is no point giving a safe medicine which is not working and the patient is screaming in pain. The key word here is, are these side effects reversible or not? And the good news is, yes, most of them are reversible. Most of them. You have an ulcer, it's going to heal. You have fluid retention, it's going to heal. You have some tubular necrosis in the kidney, yes, it is going to heal. It is not that it's going to shut down completely. Have a serious side effect. The only serious side effect is that cardiac events where there is a thrombotic event. Then we don't know whether the patient itself is prone to that. Like some patients are prone to some cardiac events of the vaccine or after COVID, and some patients are not.
Sir, there is last question for Dr. Suri, sir. Dr. Mehta is asking, what will be the effect of Polmacoxib on carbonic anhydrase inhibition? What will be the side effect because of carbonic anhydrase inhibition?
See, carbonic anhydrase is basically required for it's a buffering agent. It's a buffering agent for carbon dioxide and soda and bicarbonates. But the dose of this Polmacoxib is very small, very small doses.
Right.
That doesn't lead to any generalized effect on carbonic anhydrase. They have checked it in various trials, even mechanistic studies they have seen in rat models also, that there is no issue related to carbonic anhydrase related issues. Systematic.
Yes. Thank you, sir. Thank you so much. This point need to be get clarified because many of the clinicians were asking, is there any side effect related to carbonic anhydrase inhibition? So thank you for clearing this doubt, sir.
Because there is one molecule that is Diamox.
Yes, sir.
Acetolamide. That is carbonic anhydrase inhibitor, and that has got a lot of neurological side effects that leads to tingling sensation, paresthesias, and that is being used in eye ophthalmological cases for glaucoma cases, and also mountain sickness type of patients. Right. We have used this molecule, but they have got certain side effects.
Right. So I would like to thank both of our speakers for clarifying our doubts. Now, for vote of thanks, I would like to invite our president, Mr. Gagan Atrija, sir. Over to you, sir.
Yeah, before I give my vote of thanks, I would like to disclose that I have two brothers here on my screen. One is Dr. Sandeep Suri from North, and another is Dr. Abheek Kar from Kolkata. Dr. Sandeep, you will be very happy to know, in fact, when Dr. Abheek was a student in National Medical College, he was a class fellow of my younger brother. And we know, I think, since 1991. So I was like a local guardian for them. and Dr. Sandeep Suri is from Hisar. So, I mean, bachpan se jante hai, you can say that. That's a great day for me today because on the screen I can see two faces who are very close to me. So, good afternoon, everybody. On behalf of Eris Lifesciences, I would like to extend my heartfelt gratitude to all of you for joining us today and making this webinar a resounding success. It has been an incredible experience, and I am honored to have an opportunity to extend vote of thanks. First and the foremost, I would like to express my deepest appreciations to our esteemed speakers, Dr. Abheek Kar, who is a senior orthopedic surgeon from Kolkata, Dr. Sandeep Suri, senior consultant diabetologist from Hisar. Thank you for sharing your invaluable insights, knowledge, and experience with us today. Your engaging presentation has undoubtedly left a lasting impact on all of us. And we are truly grateful for the time and effort you have put into preparing for this webinar. I would like to acknowledge the entire audience watching the live stream. I think around more than 2,500 logins are there. So I would like to acknowledge the entire audience watching the live stream from various locations. Your virtual presence and support are equally important to us. We hope that you found this webinar insightful and it would help you with valuable takeaways that you can apply to your clinical setup. In conclusion, I would like to reiterate our gratitude to everyone involved in making this webinar a tremendous success. Your collective efforts have made this event informative, engaging, and really memorable. We are truly grateful for your participation and we hope to have the pleasure of hosting you again in our future events. So thank you once again and have a wonderful day. Thank you so much. Thank you, Dr. Abheek. Thank you, Dr. Sandeep.
Bye. Bye.
Thank you. Bye.
Yes. Yep.
Thank you. Thank you so much.
बोलो हमको छुट्टी थी तो मैं